So welcome, dear participants of the webinar number 13 of the ISG. This time we have the topic of how to start a uveitis clinic, something which was suggested from one of the participants. We take that topic very, very honest. I think it's very important to increase the awareness of uveitis, to increase the numbers of experts. And if you're missing in the beginning something from the basis, we will try to summarize that in the panel, which is on number 6 here, the last 20 minutes. I think you know how the system works. If you want to get a CME point, you will receive a questionnaire at the end, and to send that back will allow you to get all the documents and CME reports which you need. Okay, please only use the question and answer points here, not the chat. We will not answer anything in the chat. This is actually only for the faculty, but question and answers, we are happy to answer these things even after the meeting in case we do not have too much time. So please enjoy this course, and we will start with Mark de Smet, who talks about from university to private practice, which is in Switzerland.
So thank you very much, Manfred. And this is maybe in some ways an introduction to the topic. It'll cover more general aspects and a little bit about uveitis itself. For those who don't know me, I started my career in ophthalmology, well, before ophthalmology in Canada. I spent nearly 9 years at the NIH, where I did my fellowship and was on staff, and also then did a fellowship in vitreoretinal surgery. I headed a department in the Netherlands for 10 years in Amsterdam, and then switched to part-time private practice. So I'd like to consider that switch so that people early in their career or later may consider it, and then some specific aspects with regards to uveitis. Why do we choose academics? Well, for one, it's a more exciting patient care, more complex patients. Usually you can take time to really try to solve and see the end result, particularly in complex cases. You get to do research, teaching and mentorship are important aspects, and usually one of the reasons why people want to stay in academics. And there is, for those who start, really continuity and safety. Since you're coming out of a residency, it's essentially a continuation of what you've done, but you're assuming another level of role, which is more or less based on what you've learned from your mentors. And maybe a very important aspect is that there is a minimal administrative hassle, which in fact, if you go into private practice, you have to assume if you do it on your own, or certainly is taken care of by the situation in which you go. Making the choice out of your residency, the ones who end up in academics usually either are able, with their mentors and their support, the university potentially or the department, to get some grants for research early on. They tend to have published a bit more papers during their residency and spent more time trying to do some research, while those who go into non-academics right away have spent less time trying to acquire these skills, which are very useful once you go out. But the difference is not necessarily all that great. The biggest difference comes in more in terms of the time spent doing research and the time spent having publications. However, with regards to life choices, the number of children, your happiness, the type of career that you take, they're very much similar in both sides. What's interesting is that at least for these publications in surgery, so we'll go from here, and essentially it doesn't show much change, as I said. If we look at happiness factors, they're about the same in all of them. It's interesting that academics tend to recommend a surgical career, ophthalmology, more than people in private practice, and we could always discuss that another time. Having completed a fellowship, obviously for uveitis is a given. What happens is that over time you find that people that have been in practice for 10 or more years, that's when very often a switch towards private practice is being considered, and while other factors are less important. What happens if you want to go and become a professor later on? Does the fact that you've gone to private practice cause a problem? Not necessarily. If you want to become an associate assistant professor, having 7 to 10 years of practice in the periphery might be useful. Getting to a full professorship is very rare if you've come out of private practice. It is possible if you have a very, very specific expertise that has been gained over years. And then usually you have over 20 years of experience, either in industry, in practice, or in other settings. I think the pressures of let's say, academic life are well known to everybody. There is usually less patients that are being seen, particularly in ophthalmology, or 1-to-2 mix. There's a lot more non-clinical work required. It's about a 5-to-1 split, so that, and most people complain not about the teaching, research, and writing, but administration. And I can tell you that when I became a chair, that was probably the most difficult part, is the administration bureaucracy, and in particular, the lack of support to be able to cover all of these and be able to continue with teaching and research. And that's what pushed me a little bit towards coming back to my areas of, let's say, interest, which was the clinical side of things and the research, and had to give up to some extent teaching, although I do it through this and other means. What about private practice? There are things, of course, that are also specific to this, and this is risk management. We have a lot of different types of risk, and I'll just look at two of them. One of which is the business risk management. So you have to look at in your own practice whether there are certain weaknesses, there can be threats from others, or there may be opportunities. With regards to what I do, I'm a vitreoretinal surgeon and uveitis expert. There was already some uveitis expertise out in the periphery where I came here in Switzerland, but no private vitreoretinal surgery, although that very quickly developed after I started the first such clinic in Lausanne, where I'm based. There are financial risks you need to assume, high capital investments. There is uncertainty in reimbursement, particularly today, and that is overall in the world where there is more and more pressure on reducing costs. And so you have to make sure that you're not aiming too big and that it is realistic. The stated reasons for leaving include income disparity, excess administration I've already mentioned, lack of support, the lack of protective academic time, and for many people who do more clinical and teaching work than research, very often in universities it isn't quite as valued, and you can see the reasons that have been stated here on the graph. So what happens? Why would you transition? Well, you have to know, you have to ask questions yourself. You have to know yourself and know what you're looking for short and long term. Do you want to get into private practice and stay there? Is it because of certain aspects of the academic world that you don't like and you want some experience in the periphery and be able to come back? And the balance between the two is very nicely outlined in this article that is indicated here from the World Wide Web. It does give you more autonomy, so you're able to choose the setup that you want. And I ended up getting a practice where I work 2.5 to 3 days a week. And the rest of the time I do consulting, and I continue doing research with a number of people around the world. There's more continuity of care, and this is maybe more so outside of uveitis, but you're going to follow your patients more, so you'll be better able to know what the ultimate outcome is 2, 3, 4, 10 years down the road. And you have flexible scheduling much better than you can in an academic world. Research and innovation is possible in private practice. It's going to be more patient resource based. It'll depend on the number of patients you have. You can certainly participate in clinical trials if you have access to given patients. You can participate in advisory boards in societies like the IUSG. You can also do research for the industry. In regards to teaching, as long as you keep some kind of alignment with the university, preferably close to where you trained, as part-time faculty, you can have fellows and students, you'll take part in seminars and webinars, and innovation as such can happen everywhere, whether it's academic or private practice. With a private practice, though, you're going to have to do extra work. You'll have to reach out to the community, do some educational programs to teach people that are out in the community, both patients as well as physicians, what you're offering, and make sure that you maintain these contacts. You may have to do more dinners where you go to clubs, social clubs in the area where you live, or local societies, so that they're aware of your expertise and make use of it, and not just refer, for example, to a university which may be far away. And today I would say you need to develop a presence both on websites as well as in social media. Now, there are, of course, other means of developing yourself beyond the academic world. You can do consulting in industry that is based on your past experience and expertise, for example, in that you've acquired in the university in setting up clinical studies, in developing new programs with new medications or equipment. You can also participate in program developments for different types of organizations. Be part of a startup, or as you'll hear later, also try to develop a teaching program for the third world. When is a good time to transition? Well, you're the only one who knows, and maybe God, and it's based on your ambition and personal choices. My general recommendation would be to do it as late as possible, acquire as much as knowledge and expertise as you can in an academic center, both in setting up studies, participating in research, but also in gaining clinical experience, so that you're more and more independent over time when you go out into practice. It's not a one-way street. There's always the possibility of coming back, and what you learn in the periphery is quite different from what you might have in an academic setting, and I think equally valuable. You do need an adequate technical platform, sufficient training, and patient access, but if you have these, today, at least in ophthalmology, private practice is essentially the same as academics. And in fact, in the US, they faced this in the 90s, where it was very hard to retain people in academic centers, because with a good setup, we can do virtually everything in the periphery. So what kind of practice would you choose? Solo practice was the traditional way. It does present more risk in some ways because you're on your own, less contact with other physicians, and in uveitis, that's particularly important. We need contacts with other specialists, and that's much easier to do either in a academic setting, or otherwise if you're in a large community hospital where you do have all specialties that are present. Group practice, of course, gives you more the opportunity to interact with other subspecialties. Even within ophthalmology, we need people that know about glaucoma, about anterior segment and cornea and retina. So having access to these other people can be very useful. And group practice obviously allows you to cross consult with people that get to know better your patients as well as your expectations. Private clinics can also be a solution, particularly if they're large enough and cover most of ophthalmology. But very often private clinics are very close to equity investors. And what they do is they buy large practices and clinics. They expect to be able to get money back from it. And so they'll dissuade you in some ways of trying to treat the most complex patients unless they're going to involve surgery. So it's very important that you look at the exact setup where you're coming in, the local environment. And that is, to some extent, the community support you can expect from the city, the local government, the presence of colleagues, and university support. If you're leaving the university, it's good that your chairman, the people that are there, you can still consult, even if you're going to be several hundreds of kilometers away, because you may want to refer patients back to them and get patients from them referred to you. Patient access obviously is important, and if you're selecting a particular place to set up an office, look at the density of subspecialists in that specific area, particularly ones that have expertise similar to yours. And of course, be very, very careful with regards to your own expectations. Nothing is set in stone, and you could evolve, for example, from a group practice or community care hospital to a more solo practice later on, realizing that for solo practice, you still need to have a place where you can do surgery. And while in the US, it may be easy with people that do, let's say, anterior segment surgery to have a surgery center, for retina, it becomes a lot more complicated. But with a group practice, of course, that's a possibility. What should you look for if you're going to join a practice, or what are you going to need to acquire? Well, for one thing, in a private practice, you need to manage the human resources, your secretaries, your technicians, and that demands a certain degree of expertise. Billing you have to do on your own. It's not the university doing you for it. You have to be able to recruit your patients and make sure that both patients, physicians, and specialists know that you exist. And you have to be able to keep up to date. And so I've taken this out of this article, and they say, yeah, particularly in the beginning, you're going to have to be your own business manager. You'll have to know something about billing and coding and bookkeeping, human resources, become the chief executive officer, etc. These are all true. Of course, if you do it with more than one individual, you can share the tasks, but of course, one person has to lead. And I think the most important advice that can be given here is you should get professional advice outside of what we've learned as physicians and as on our career to become a specialist, because these are things that we don't necessarily learn unless you're confronted with it, for example, in part being a head of a department. There are courses available through, for example, the American Academy of Ophthalmology and others. And in each country, there are associations that can give you the important information and provide you the adequate help to carry this out. Now, it's also important to realize that if you're going to join a practice or start a practice, you're bringing something unique, and you're going to reinforce a practice, or you're going by being an extra hand, or you're going to provide a new resource. Most likely, you're going to be the first person who comes with uveitis expertise in this particular practice, and you're probably also a subspecialist in another area. So this is very important, both the subspecialties you have, whether you have experience in clinical trials, if you've been able to run in the past research, clinical or basic, and you have this mindset to be able to develop new things. These are skills that you'll be able to bring. And so you need to know the skills that you'll bring. And the other important aspect is that each physician that joins a practice brings a network of contacts. And one should not underestimate what that can represent for a starting or existing practice. Pay is not the most important factor. It's in fact how the clinic is being run, how the people look at setting up the practice and the type of care they're wanting to give to their patients. And I think that's where you should focus your attention on when you're trying to select either the model or the location or the group of people you're going to join. What should you expect? Most articles that I've looked at and in speaking to people, they all say, well, the reason for private practice is because you make more money. And this is true over time. If you look at many articles, they'll say that the break-even point between being in private practice and leaving academics is somewhere between 3 and 5 years. By break-even, it means that after this time, you'll be earning more than you would have had you stayed in academics. But in those first few years, you can in fact be at a high financial risk. You might even go broke. If you opened the practice just before COVID, it would have been very difficult. And so it's important to realize some of these other aspects of going out. You earn more, but your overhead expenses are higher. Ideally for ophthalmology, they should be about 30%, but they can easily be 40 or 50. We have a high capital investment. You need OCTs, we need all kinds of slit lamps and many other machines that are required in order to do decent investigations. And these have to come out from your investment. You also need sufficient support staff. And in looking around, particularly in North America, in busy practices where some retina experts see 100 patients a day, they have, in fact, one ophthalmic assistant for each 10 patients seen in a given day. So that's a lot of support staff that is required, and the need for a personnel manager. You should have cross-trained personnel. That makes it a lot easier. And I think having part-time people also gives you more flexibility, because very often these people can be set in if somebody falls ill, develops COVID or something else. What about uveitis? Well, expertise is obviously important. The more experience you have, the easier it will be to carry out in private practice your specialty. You need sufficient access to patients so that you can also stay up to date with new developments. I've already mentioned the importance of equipment. What's also important is having a good base of consultants in other disciplines, people that understand what you're doing and what you require. And it goes from pediatricians to rheumatologists to immunologists. And to give you an example, I worked for a small period of time in Belgium, and the rheumatologist there, when it came to treating children with methotrexate, never wanted to give the dose that was really required, because in his eyes, there was no systemic disease. So why give a high enough dose that potentially could have some degree of toxicity? And so some of these patients had ongoing inflammation when using methotrexate, and I had to switch to another drug. You also need a good reference laboratory. And I'm fortunate here in Switzerland that there is a lab that sends around small cars that pick up blood samples, and they can do virtually any blood sample that is required. Not so much when we're looking at anterior chamber analysis, but I can draw the blood and get the results instead of having to depend on other people. And I think it's important also to participate in regional and national uveitis specialty groups, because they'll tell you about what's going on locally, how to set things up, and what more or less the local standards are. And finally, if you're going to transition, I think these are important points to consider. There is always a fear to go from academics to private practice. Hopefully, I've been able to get rid of this and also tell you that you can go back if you want. You'll definitely depend on the support from your spouse, friends and families and colleagues and mentors. There is no perfect fit. It's a journey, and it will have to adapt as it would if you're staying in academics. Start small, not too big, because otherwise it may financially not be viable. Invest and foster in your team. Be patient and be realistic. It takes time. Expect some setbacks. Everybody gets them as you're starting to set up a practice. And you're going to start, you should chart your own course, do it, and notice that it's going to, as long as you keep in motion and keep moving, things will always work out. This is a reality of life for everyone. Thank you.
Thanks, Mark. Very nice. I think we will cover some of these single ideas again during the other talks, and would like to have Sumyava Basu now to talk about from the academic uveitis in a high volume setting in India.
So, good evening, everyone. And it's wonderful that IUSG has chosen this topic for discussion. Thankful to Professor Zirut for considering me for this talk on academic uveitis in a high volume setting. Now, when I think of these words, academic uveitis and a high volume setting, the most direct example that comes to my mind is that of the story of the trematode-induced uveitis. Now, this story is from Aravind Eye Hospital in Madurai in South India, for those of you who are not aware. And it started with the observation of these conglomerate anterior chamber granuloma. This was noted by Professor Ratnam, whose picture here is from the early days of her career. And she found that unlike other granuloma in TB endemic countries where they're often treated with anti-TB drugs, these were not responding to the anti-TB drugs or to corticosteroids. She looked at the cases over the past 6 years, and there were more than 200 such cases of pediatric uveitis where the granuloma did not respond to treatment and the eyes went to phthisis. And in fact, she found that 40 boys of these 200 kids were from one single village. Then she followed them up and found that all these kids were bathing in one pond. And when she did a histopathological evaluation of these granuloma, it was found that this trematode was, which is called as Prociborium varium, was lying within this granuloma. Thereafter, of course, it's a long story which has stretched over more than 2 decades now. And it was found that this trematode is found inside these snails, which are the first intermediate hosts. And there are fish which eat these snails, and birds which eat the fish, which are actually the definitive host for these trematodes. Now, all this research had a huge impact on this particular form of uveitis. This was reported from several other locations, both in India and in other parts of the world. A molecular diagnosis for this trematode-induced uveitis was found by quantitative PCR, and because of this accurate diagnosis, it was possible to avoid unnecessary anti-TB treatment in these kids. Most importantly, they found a way to prevent such kind of intraocular inflammation by advising the villagers to avoid these contaminated ponds or to clean the ponds in their localities. Such a huge impact from the research which originated in the clinic. So what are the lessons that we learn here? The first lesson is that there are tremendous opportunities in high volume settings. The more you see, the more you ask. The second thing is that these are our problems. Nobody is going to look into these problems for us. So it's up to us to find solutions for these problems. And once you have found a solution, the impact is very immediate. Now, for the purpose of this talk, I spoke to 3 individuals from India, Professor Amod Gupta, Dr. Jyotirmay Biswas, and Dr. Ratinam, about their views on academic uveitis in these high volume settings, because all 3 of these individuals have excelled in this kind of a scenario. So what is academic medicine? Academic medicine, the essence lies in thinking more about the work that you're doing. This enhanced thinking leads to teaching, learning, and further studies, innovation, research, and discoveries, which ultimately lead to an improvement in the healthcare. The ultimate goal can be found in the statement that it lies in the development of basic principles, effective policies, and the best practices in healthcare. And what is high volume? Now, when we talk of high volume, it can be considered in 2 ways. One is the general patient volume in the clinic, and the other is the disease or procedure specific volume. Now, the disease or procedure specific volume could depend on the prevalence of the disease. It could depend on the specialty of a particular clinician or the pioneering work done by that person, and is not always associated with overall high volumes in the clinic. On the other hand, high overall patient volumes, which is the context of this presentation, is generally found in tertiary care centers or multidisciplinary hospitals. They're usually, but not always, located in the major cities and have a component of medical education, undergraduate and above, and may or may not incorporate research, policy, and planning. Now, what are the opportunities for research in such high volume settings? Now, research here is driven by the type of patients that are coming here. You see problems, you identify the problems in your patient population, and you try to find solutions for them. It's a good escape from the mundane, repetitive tasks that we tend to do in such high volume settings. And it's a good vent for the curious mind that many of us may have. Once you have started your research, the speed is also very high because the patient volumes are very high to conduct that kind of research. And the application is very immediate. We found the example in the case of trematode-induced uveitis. So it starts on the bedside, goes to the bench, and again comes back to the bedside. Now, besides research, like I mentioned on the slide on academic medicine, there's also scope for education, and because the clinical material is so exhaustive, you have a good scope for bedside teaching of both a large variety and a large complexity of cases in your clinic. There is also a good scope for multidisciplinary approach, not only amongst different ophthalmic subspecialties, but also a large number of non-ophthalmic specialties depending on the kind of setup you are. And ultimately, education leads to more research questions, and once you find solutions through those research, that feeds the education again. So this becomes like a positive cycle here. There's also a good scope for health policy and planning, but we are not going to that discussion today in this session. Now, what stops us from carrying out academic uveitis in our high volume settings? Usually people would put the blame on the clinical overload, the large number of patients, time constraints, the difficulty in carrying out all investigations, or the incomplete documentation. But that is not the truth. The truth, the real culprits lie in our failure to question what we cannot explain by our understanding of the subject, and also our tendency to accept the norm or what we have read in the textbooks or in published literature. So here is a great example from the PGI Chandigarh, and this information I got through direct discussion with Professor Amod Gupta. So the story of serpiginous-like choroiditis. I think all of us who are attending this session today are familiar with the tubercular origin of serpiginous-like choroiditis now. Now, if you look into the entire story that probably started somewhere in the late 80s, it's a story of meticulous documentation, very keen observation, and a collaboration with internists and other physicians. Now, this group published two important papers, which were, of course, followed up by a large number of other papers from their own centers and other centers across the world. The first paper was published in 2002, and it was only called as serpiginous choroidopathy in North India. At that point of time, the authors did not have much clue about the link with tuberculosis. The main thing that they found here was that this serpiginous choroidopathy was not fitting into the literature that was available on serpiginous choroiditis from the Western world, and it was also not fitting into the literature on AMPI, which was available from the Western world. Again, these patients were younger. They usually had unilateral disease, unlike the previously reported serpiginous choroiditis or AMPI. The disease was multifocal, and the serpiginous type pattern tend to progress in a wave-like pattern. They, based on their understanding at that point of time, treated all these patients with corticosteroids and or cyclophosphamide, and most of these lesions actually resolved, and although many of them came back with recurrence as well. Interestingly, in this paper, they also quote that the lab tests for TB or for syphilis and also for the viral infections were unremarkable in all the groups. It was around this time that they collaborated with a prominent physician in their institute who suggested that at least some of these patients were showing a very high reaction to the tuberculin skin test. That is when they started noticing the association with tuberculosis. So the importance of collaboration comes in here. Then they published this small series. You see, the previous one had more than 100 patients, but this is only a small series at that point of time of only 7 patients. But all these 7 patients had a very strong association with tuberculosis. The Montu reaction was more than 20 millimeters. All of them had an abnormal chest radiograph. PCR of the vitreous samples were positive in 5 of the 7 samples for tuberculosis. 2 of the 7 were positive for a lymph node biopsy, and 1 of them even had a positive sputum evaluation. Thereafter, they went on to treat these patients with anti-TB drugs and corticosteroids, and the rest is history. So with this background, when we decide to start uveitis practice in a high volume setting, how do we manage our case? The first part, of course, is building the service. Like Professor Zerut mentioned right in the beginning, you first need to get all the official approvals. You need to talk to your bosses, convince them that a uveitis practice is very much essential for your clinic or for the hospital. Then you connect with the other disciplines, the internist, the rheumatologist, pediatrician, pulmonologist, etc. Find the adequate lab support, and this may be challenging in a lot of places. Get the right biochemistry investigations. Make sure that the quality of those investigations is up to the mark. Then immunology, microbiology, pathology, and of course, radiology. Sync your electronic medical records, knowing that most of us are now using these electronic medical records. Sync them with the uveitis practice. Start building your team. You may think that the team consists mainly of clinicians. No, the more important team probably consists of the optometrist, the outpatient nurse or counselor, and the trainees who later join your practice. So all of these together will actually help in serving the patients. You can't do these things alone. And at some point of time, you have to consider adding fellow clinicians, because uveitis is a chronic disease, and at some point of time you will definitely need to leave the practice for some other work or a holiday or vacation, and you will need support from the fellow clinicians. Now, the other part of getting started is developing the protocols, and this consists of building the pre-evaluation data sheet, which the patient needs to fill up about the systemic conditions, etc. Preparing a uveitis data set, which includes a basic data set for all the uveitis patients and an extended data set for a specific type of uveitis. Develop lab algorithms. Of course, this is beyond the scope of this talk, but this could include some essential tests and some tailored investigations depending on the clinical presentation, and also patient information sheets which need to be distributed to the patients about the type of disease or the type of treatment that these patients are being given. Now, while there's a ton of wonderful literature on uveitis, on the approach to uveitis, these are two papers by Professor Doug Jabs, which I recommend routinely to all my fellows at our clinic. One is published in 2013 in AJO, the approach to the diagnosis, and the other one, I think, in 2017, again in the AJO, on immunosuppression in uveitis. I think these are wonderful papers to get started with your understanding of uveitis. The data set part, if you look at the publication from the Royal College in UK, you will find a nice compilation of the basic and the extended data sets that you should be collecting for all your patients of uveitis. Now, once you have set up your lab, you would want to begin your research. And again, in this, there are two parts. One is the general part of any research, and the other is the uveitis specific part. As I mentioned earlier, the limitations are not about resources of time, manpower, or funding. More often, the limitation is with the intent, and that is which we need to develop first before we begin our research. The other thing is to find a very relevant research question which applies to a lot of patients who are attending your clinic. You read up the literature, find the gaps in the literature, and also find questions which can explain some of the clinical observations that you have found in your clinic, which are otherwise unexplained by the available literature. The next part is to be very thorough with the documentation of history, clinical science, imaging, lab tests, and the complications. The collaboration, which can't be emphasized enough, with other specialties in ophthalmology, in medicine, and also with the basic scientists. And finally, we have to learn the skills of time management, because we ultimately need to address our patients as well and learn the skills of manuscript writing. Now, some points that are specific to uveitis are the importance of learning uveitis nomenclature, especially that comes from the Sun classification system, the different classification systems of other types of uveitis, tuberculosis being an example here, and also a basic understanding of immunology, molecular biology, and pathology when you get started with your research. Now, I would like to close with a short glimpse of our journey in the pathogenesis of ocular TB. We mainly focused on two questions. The first one was to address the question of intraocular infection versus a remote infection in ocular TB. This is very commonly stated in any discussion on ocular TB, but nobody really tried to look at what actually is happening in the pathogenesis of this condition. We also wanted to address the myth of hypersensitivity reaction, which again is very commonly stated, but there is no real evidence of any hypersensitivity reaction happening in this condition. And our focus was on the clinical phenotype of TB retinal vasculitis. The other area that we addressed was on the search for autoimmunity, because like I mentioned in the earlier discussion on serpiginous like choroiditis, a large number of these patients would resolve with corticosteroids or immunosuppressive therapy alone. Of course, many of them would recur in the later stages, but they did respond to such anti-inflammatory therapy. So we were thinking of the possibility of autoimmunity, and also the phenotypic similarities of many forms of ocular TB with the uveitis entities, made us look for autoimmunity. So about the part on establishing the evidence of infection in the eye, we followed what many other centers were also doing, looking at the molecular diagnostics. We tried multi-target PCR. In fact, we still have one of the largest series on PCR proven ocular TB in the literature. We devised new forms of molecular diagnosis, such as the loop-mediated amplification, which we reported, I think, in 2012, and something called as the normalized quantitative PCR. We did a histopathological study of lesions like this from a non-enucleated eye, because most of the histological studies on ocular TB were from enucleated eyes, but we took a sample of retina from a patient with a retinal detachment, and we demonstrated that these lesions, which we thought as choroidal granuloma, were actually intraretinal granuloma lying inside the retina. We also stained them with the immunostaining for HLA-DR, which is a marker for macrophages. So thereafter, we did clinical studies where we have now predicted we have demonstrated the clinical predictors for TB retinal vasculitis, such active retinitis lesions, as you see here, or the heel lesions. And we found a new sign, which we called as focal vascular tortuosity, which you can see in the fluorescein angiogram very clearly. Finally, we also demonstrated the response to anti-TB therapy alone without the corticosteroids, at least in select cases of these TB retinal vasculitis, which really established the role of infection in the genesis of this condition. The other thing that we did was to develop a zebrafish model of ocular tuberculosis, where we injected the zebrafish embryo with the mycobacteria of a fish called as Mycobacterium marinum, and through live imaging of fluorescent tagged mycobacteria and fluorescent tagged macrophages, we could demonstrate the crossing of the blood retinal barriers by the macrophages and by the mycobacteria, and the formation of granuloma inside the eye during the mycobacterial infection. The other thing that we did was looking at the intraocular autoimmunity, and we demonstrated the cytokine response to retinal crude antigen, the RCE that you see here is the cytokine response to retinal crude antigen, and the ESAT6, as some of you might know, is a TB antigen. So we demonstrated that there was a immune response to both TB antigens and retinal autoantigens in patients with ocular tuberculosis, with the autoantigen specific cells being more resistant to the activation induced cell death. I'm not going into the details here, but it's interesting how we, developed these kind of ideas. The idea of ESAT6 actually came from a TB researcher in Berlin who I had contacted several years ago, and during a general discussion, he just suggested that why don't you use ESAT6 to look at the TB response in the eye. And the idea of the retinal crude antigen came from a paper on birdshot chorioretinopathy from Netherlands, which actually had studied only 2 eyes where the retinal crude antigen was used to demonstrate autoimmunity in the vitreous cells in birdshot chorioretinopathy. So, you just have to keep your horizons open, and I'm sure these ideas will keep coming into your mind. Our current research is looking at compartmentalizing infection and autoimmunity in different types of ocular tuberculosis. A quick word on education. I'm sure Professor Zerut is going to cover this in much detail in his presentation. But education, as we now realize with what COVID has shown us, it can be both conventional education as well as virtual education, and both are equally important. Conventional education, as you know, it consists of residency programs, fellowships, observerships. It prepares the next generation of physicians to take over the clinical care of patients. It helps in reaching out to relatively underserved areas in your population. And also, what I personally feel is very critical is that you learn as much while you teach others on a particular subject. Now, virtual education for a long time used to be mainly about webinars, either by societies or by institutions. But as we can see in this IUSG webinar series, that you can also have a very long-term engagement with a number of people through online education. The other example of this kind of a long-term engagement is what we have been conducting for the past 7 months or so, which we call as the LVPI Uveitis course. And this has taught us how much we can cover in uveitis training, especially because it is not very well covered in usual residency programs, and this does not match very well with the high prevalence of uveitis in the community. The uveitis in particular, in comparison to other subspecialties, offers us a very wonderful way to teach, which you don't see in other specialties, because of the possibility of image-based learning in uveitis. There is, compared to say retina or cornea, there is relatively less requirement for hands-on experiences in uveitis. It also helps in inculcating this uveitis thinking process, and while doing these long-term programs. And it's amazing how you can have such a large number of fellows, online fellows. We are currently having more than 150 people who are following us on a weekly basis in our online course, and 30 plus of these registrations are from outside India. So the scope is huge, and it's up to us how much we can make use of this opportunity. To summarize, there is a great opportunity for academic uveitis in these high volume settings. We have to find our problems and the solutions for our own problems. Nobody is going to do them for us. And we don't have to bother about the resources. It's the intent that really matters. And that is what is needed for academic uveitis in our high volume settings. Thank you so much for your attention.
Well, thanks very much for this very nice presentation. We're a little bit over time, actually, and I would like to invite John Campen now to give his experience coming from university to Africa, means Ethiopia. John, welcome.
Thank you very much, Manfred. So this is an unusual talk for me. I'm going to just sort of describe my experience in making a major transition from sort of a more traditional academic setting in the United States to starting a whole program in Addis Ababa, Ethiopia. So just a bit of background about myself. I trained in ophthalmology in the early 90s and then proceeded to what was called Public Health Ophthalmology program at Johns Hopkins, got additional degrees about research mostly, and embarked on an academic medical career in 1998. And I initially started focusing on ocular complications of AIDS, sort of thinking that was the disease of the century, but that was just at the time that the antiretroviral therapy became available and the whole world was changed. You know, may it happen so for diabetes and inflammatory diseases as well. And so that rapidly became sort of mostly about presbyopia in that patient group as the underlying disease was controlled, and focused then primarily on uveitis and ocular inflammation after that, and pursued a career largely focusing on research funded by NIH grants. So I began at Johns Hopkins and was a faculty member there for 7 years, from 98 until 2005. And then I moved to Penn, which was where my wife's family was located, and in Philadelphia, and was there for 10 years, basically, and rose to full professor with tenure in 2013. And by God's grace was largely, I think, recognized as the main uveitis clinician in that area of about 10 to 20 million people, and carrying out research in some NIH-funded studies like the SITE study and the MUST trial and the successor studies to that, as well as others. So, but then I shifted in 2015, so that was overlapping 1 year still under Penn to Ethiopia, which I'll tell you about. And then that led to needing to shift to Mass Pioneer and Harvard about a year later. So let me just talk about this change and how we went about it. So my main motivations to make this change were sort of my own personal Christian discipleship, and my wife trying to follow Christ and make a difference in an area that needed development, even though it was costly. We also, sort of from a more theoretical perspective, wanted to try to establish proof of concept that a self-sustaining, cross-subsidizing model, as pioneered in India, like we just heard about from L.V. Prasad, could be workable in Africa. And that's sort of a larger ophthalmology picture, not just uveitis only. We plan to establish a uveitis subspecialty practice in that area, which didn't, as far as we knew, have any specialists for about 1 billion people. And we plan to develop an academic center, so not just clinical services, but training and research. And so set out to develop clinical research capacity as well. So because of that, then I had planned to continue as a clinician investigator and not just seeing patients, since being a clinician investigator is maybe my best competency. And so because of that, I wanted to continue doing academic research and continue the grant programs at that time. We're still working on the SITE 2 mortality and several analysis grants about cataract and remission of uveitis, which are still sort of trickling out, as well as we still hadn't finished the primary MUST paper, which I finished in 2017 with my colleagues, and had several active grants. And so I needed to have a U.S. academic appointment with a department that would be willing to have me basically telecommute and live overseas. And so I thought that that would be possible since in the United States, U.S. academic centers typically require us to raise our own support. We basically have to raise the money ourselves through grants and clinical revenue. And so I was about 80% from grants, 60 to 8, I guess, yeah, in general, that was the target, was 80% from grants. And so then I transitioned from the clinical revenue to support from Sight for Souls from many generous donors to carry out the work overseas. So it's about balanced between those two sources now. And Penn, the department was receptive, but the dean's office sort of eventually kind of let me know that they didn't want me doing that. So I eventually transitioned to Mass Eye and Ear that was more open to the model, and that's worked out quite well, really. All right, so then just thinking about this and why we ended up choosing Ethiopia. So at the time I was thinking this through, Ethiopia had and still has the second largest population in Africa after Nigeria, about 90 million at that time. Now it's about 115 million. And at the time they had about one ophthalmologist per 750,000, which is actually not that unusual for Africa, unfortunately. And it's actually improved somewhat since then, maybe one per 500,000 now. The number of people undergoing cataract surgery was relatively low, even though the number of people with blindness was very high, especially taking into account the age of the population. There was a need for more training, although it was really more at the fellowship level, because there were 5 residency programs at that time. So actually, at the present time, I think 1 out of every 4 ophthalmologists is a resident. So there's kind of, a lot of development going on, but it wasn't going as well at that time. Some of the programs really had very limited, I think one only had 1 faculty member for 6 residents per year. Others were pretty well staffed. And there weren't any subspecialty fellowship programs, and so this was sort of a big opportunity. In fact, at that time, in all of Eastern Africa, there was only, I think, a retina program in Tanzania, I think was the only program in the whole region doing fellowship training. And Ethiopia also had the special interest in trachoma, which was an area I thought would be a good one for research, and indeed has proven so. It's also a country that had development happening, at least in the main city, and so we thought that a cross-subsidization model would work, that there are people that can afford to pay, $10 or $20 for a visit. I think we're charging $8 now, and could pay for cataract surgery and then subsidize the poor that way along the Indian model. And it's an influential site and would be a good site for training, with the African Union based there as a diplomatic center and as a very well-connected center by air to the rest of the world. At the time, it was said, or I guess it was in the 2015 Vision Loss Expert Group paper, that we concluded that Ethiopia was the second worst in the world in terms of blindness after adjusting for age. Now the population age is really young, so if you look at the absolute burden, it's less because the average person is 19 years old. But as the sort of demographic transition happens and more people are old, it should have a very high risk of blindness. It was something like 10 to 15% of people over 50 were blind. There weren't any uveitis practitioners that I'm aware of, except in South Africa, in sub-Saharan Africa at that time. There were 3 retina specialists in Ethiopia at that time, and a few others in other parts of Eastern Africa. And there weren't any uveitis training programs that I know of still, other than ours at that time. I'm not sure if there might be one in South Africa, but I think they're training overseas. And Manfred and Vishali and I and others did a course in the first COEXA, which is the College of Ophthalmology of Eastern, Central, and Southern Africa conference, I think in 2012 maybe. And there were a number of general ophthalmologists that I had come to respect that attended, and they were really kind of amazed at the concept that we could manage uveitis the way we do. And so really, there wasn't a very developed concept of managing uveitis other than just with eye drops. And from the clinical research perspective, wasn't nothing going on, but there was room for growth. Actually, there's a precedent of everyone having to do a research project to graduate from residency. So then most care was occurring in few public centers managed by residents with limited supervision. There had been some private practices established since about 2011, and some of them had OCT and photography, so that had been recently available in the community. There were a substantial number of people able to pay for services and were paying these practices, which were successful. And also it was a situation where there were a large amount of regulatory obstacles for sort of foreign input into the health sector, and so this created a lot of difficulties for us. So how did we go about implementing the program? So I'm starting with the sort of whole program because there wasn't any department that was self-sustaining other than the private practices there, and we were looking to do a not-for-profit model. So Sight for Souls then was planning to start something and fund it, and so Ethiopian regulations at that time didn't allow a foreign entity to start any healthcare organization other than an entire hospital. So we couldn't do it ourselves. And charities, in the US, we would have, like for instance, Mass Eye and Ear is a charity and doesn't take profits. And so we would like to have arranged it like that, but charities at that time weren't allowed to engage in cost recovery at all and be sustainable. So we had to solve that problem. We wanted to set up in Addis Ababa because we wanted to do fellowship training and research, and so we needed to set up there. So we ultimately chose to come under a sort of leading mission hospital, which also has a medical school, which is registered as a for-profit company but just never takes profits. And so that's what we did under this hospital called Myeongsung Christian Medical Center, now called MCM Comprehensive Subspecialty Hospital, with its associated medical college. And then Sight for Souls operates the eye department under that with a sort of fee-splitting arrangement and cross-subsidizes the poor, mostly with grants over the early years, but somewhat with surplus revenue, which is the long-term goal. So this is the site. The eye department is right here in this large hospital building, and the medical school is over here, and this is where I live right here, although at the moment I'm in Seattle. So since I was already an academic ophthalmologist with some papers to present, I began going in 2009 even to speak at meetings and get to know people. We continued the site and the MUST funding from remotely. This has been actually aided a lot by the COVID development since everybody is online now. I used some accrued sabbatical time to start the transition. We started Sight for Souls, myself and the colleagues I'll mention in a minute, and we approached various foundations that contributed to the development of this program, especially Himalayan Cataract Project at a more recent time and Mass Eye and Ear, but these were the ones that helped originally, and the sort of host hospital in a way is the biggest contributor. This was the startup team. Scott Lawrence is a glaucoma specialist he was at UNC Chapel Hill at the time we started. Dr. Demese Tedesse is the regional advisor for Christoffel Blinden Mission for Eastern Africa, as a well-known ophthalmologist in that area, and Dr. Emma Bitt Getahun was not really a young ophthalmologist, but about 8 years out at that time, who was already working at the hospital, and she's the one that I ultimately trained as a uveitis specialist. So we had lots of challenges for the setup, transitioning Scott and my families, developing a sort of formal agreement with the hospital, developing space, hiring and training an initial team. Obtaining equipment was quite a difficulty since we weren't well funded, continuing research programs and writing new grants and starting training programs. So going through that briefly, I had to move my family. This was the most difficult aspect. They weren't always that happy about it. But anyway, we're pretty well established in Ethiopia now. We had to refurbish space in the hospital, so they gave us some space in the main lobby of the hospital, and with the exam we went through like 13 iterations of this, but this was the plan with the optometrists over here with 4-meter lanes so that we could do research, and then 4 ophthalmologist lanes and sites for ancillary equipment. We got the help of the Lions Aravan Institute of Community Ophthalmology to train our staff. These three were our initial staff. So 1, 2 optometrists, 1, 2, 3, 4 nurses. She was a trained refractionist already before the concept of an optometrist had been established in Ethiopia. And you can see the 4 ophthalmologists here, as well as the LICO team. We obtained equipment initially by donation or by purchasing it with money we raised from Sight for Souls, and this was quite about a year-long process to learn to go through the sort of compliance thing. Ethiopia has sort of a culture of regulation and compliance, which is not all unreasonable, but takes a lot of doing to work through things. And then the Himalayan Cataract Project offered to write a grant with us for equipment back in 2016. And so we did that together, and it was awarded to Himalayan Cataract Project by a branch of the U.S. Agency for International Development. And this gave us sort of good imaging and vitreoretinal surgery equipment, which took several years before it finally came. But this enabled us to launch Retina about a year ago. And then I put in under Mass Eye Near another such grant, which has been awarded, and so we're still in the process of doing that, which was awarded back at the end of 2020. And so this should allow us to cover all subspecialties when we have that equipment. Our outpatient growth was pretty good, about 20% per year until 2020. This is calendar year 2020, so this is when COVID came, and we had quite a problem from this, as did the whole hospital, with people being afraid to come. And so for about 6 months this was reduced, and then after that we recovered, and now we're sort of around 12 to 1,300 per month. And so since the beginning of 2021, then the clinic has been self-sustaining, despite sort of subsidizing the hospital as well. You may have heard we had a civil war going on in the country, and that's pretty much resolved now, but by the end of last year it was threatening the capital, and I had to move my family away, and so but the Ethiopians didn't seem to be as concerned as the foreigners, and so really the clinic volume wasn't nearly affected as much as by COVID, and sort of that seems to be resolved now, thankfully. We started uveitis and glaucoma services with Dr. Lawrence from the beginning, basically, and then we've added vitreoretinal surgery in 2021, and we have a cornea specialist going for training next month, and hopefully we pick up pediatric ophthalmology and oculoplastics soon, and then we could apply for a residency program at that stage. We had done a couple of fellowships, so Dr. Lawrence with Michigan and St. Paul's Millennium Medical College, one of the public centers, had trained Dr. Lemlem as a glaucoma specialist. This was also supported by Himalayan Cataract Project, and she did a lot of the training overseas. And so Dr. Lawrence has now left Ethiopia for various reasons, and so she's taken over his practice now. And then Dr. Emma Bate, one of our founding ophthalmologists, I trained personally in uveitis, and so she's now fully trained since last summer, and I think is the first African, other than the white South Africans, the first to be trained in all of sub-Saharan Africa in a full manner, doing immunosuppression and so on. So although we were aware of others who have clinics, which is good. So I continued the site and the must studies, as you probably know. The FLAME trial is a new trial about trachoma that, by God's grace, was funded and is actually my largest grant ever. And I've been participating in the vision loss expert group and some other studies. We've gotten now 4 new grants since I came. So the FLAME trial is the biggest one, 3 new site grants that are like analysis grants. And the ADVISE trial also, isn't my grant, but part of our group to do that, although I'm sort of becoming, less involved in this group at this stage. I had, if you look at the trajectory of publications, a big drop in the number of papers at first, since it was quite difficult to make this change, but then it's recovered largely now. So I had 3 of my 4 best years now since making this move, and the number of citations has been increasing over time, although this isn't sort of adjusted for inflation, because I think there's more and more papers cited all the time. So the FLAME trial is a big clinical trial going on, and so we've launched that this year after quite a bit of regulatory difficulties and COVID problems and so on, and that's going pretty well. Dr. Ida Abishal is a key Ethiopian collaborator, and Dr. Wandu Alamayu, and this is our study team. So getting to the uveitis then, we had to build the platform as well as just seeing uveitis, but we began it from the beginning, and I haven't very aggressively pursued getting everyone to send all their patients to me, because my goal is kind of development and not to just build my own practice. But we have seen about 510 distinct uveitis patients now as of about a month ago, and we have nearly completed the process of formal recognition of our fellowship program, and we should be training 2 fellows at the same time before long. What I'm planning to do is have it be a part-time fellowship where people keep their position at one of the public hospitals, and then works like 2 days a week with us when we have our uveitis clinic, and then take 1 fellow every year. So they would spend 2 years working part-time with us, and then overlapping 1 per year. We now have very good imaging capacity with the Heidelberg system, and so we can do fluorescein ICG. We have every Heidelberg option except for the anterior segment 1. We're running this now jointly with Dr. Emma Bate, so whenever I get too old, she can continue with training this program, and hopefully the other trainees as well. The uveitis service in general would have grown faster, I think, had we aggressively promoted it, but we didn't want to say that we were better than these other practices that were already successful, because we're sort of about trying to help everyone succeed and not undercut anyone. And we'll start publishing about this shortly. I have a medical student working with me, but she had to be evacuated because of the Civil War issue. Hopefully she'll be back in a couple of weeks, and we can start describing this and how we have lots of tuberculosis, very similar to what's going on in India that we just heard about. So we look to train fellows for Ethiopia and then regionally, and then to start a program with support from Mass Eye Near Global Surgery Program and Himalayan Cataract Project to sort of have a formal curriculum at the 5 residency programs, which would be something new. Manfred and the IUSG have been kind enough to appoint me as one of the IUSG ambassadors to Africa. And so I'm looking to sort of start visiting other sites more as Dr. Emma Bate now can increasingly take care of this. And I'm also looking into some other concepts, like if we can include uveitis in rapid assessments of avoidable blindness, which sort of needs some practical way of doing that. So I have some sort of nascent research agenda toward that goal, as well as to evaluate the proportion of cataract blindness caused by uveitis in Africa, which probably is not trivial and tends to not be sort of attributed to uveitis rather than to cataract in sort of our vision loss expert group syntheses of data. So why would someone do such a thing? So it's certainly not for money, but in terms of sort of need, it's maybe the last frontier for sort of scaling up uveitis to the world, since there haven't really been proper uveitis clinics or training programs in sub-Saharan Africa, except in South Africa. And, you know, we're seeing that there are a lot of people who are going blind from uveitis and that it's very treatable. It's really just, I feel like it's even more successful in treatment than it was in Philadelphia, because people really just need basic treatment. And we've been seeing, hopefully one of the things we can publish in a year or so, really rather good outcomes. I suspect that we'll see an average improvement, whereas like with sight and must, we were seeing more that they were stable over time, because often the patients are, you know, just haven't been successfully treated, or maybe were just treated with eye drops. And so there are some eyes that are just lost and we can't recover them. They're already Tysical. But there seem to be great improvement and some sort of surprises in terms of the diseases we have. There are also just opportunities that I see arising as sort of the, I guess, ability to recognize what could be done, and research is brought together with the local problems. And there's, you know, a need to develop local capacity. My Ethiopian colleagues are really very capable and just need to have opportunities, you know, and many of them have sort of just been grabbing every opportunity that they could come across to become like a really good cornea specialist or retina specialist, even though they didn't really have formal observers or formal fellowships with mentored surgery training, but just observerships. But many of them have become very good. So developing such capacity then is really the key to alleviating blindness from uveitis in this region, because just, you know, one encounter with the uveitis patient won't really make the difference, and the capacity needs to be developed to be permanently available. So what would have been easier if we were doing it over? So one of the things would be to have good funding from the beginning. Like, we were really scratching to find equipment and didn't have any imaging other than sort of basic fundus photography of the disc and macula. It was sort of good for me that I had trained uveitis in the 90s, so I could sort of live in that scenario and do pretty well. If we had started in a public center, we would have had vast numbers of patients right away, but it wouldn't have been self-sustaining, and patients mostly couldn't afford the treatment, although a charity perhaps could address that issue. So like, there would be more patients had we taken that approach, but we wanted to sort of do something permanent that could sustain itself. And if we had grafted onto an existing well-run center, it might have moved faster. Say one of the for-profit centers, which I might have considered doing if I was doing it over again, because it's not, I think, unethical for people to make profits. But we were hoping to have it be not-for-profit so that more patients could benefit from it over time. And part of our goal was to, you know, not just about uveitis, but about starting a whole clinic and academic program from along the Indian model. So thank you very much, and I guess we can answer any questions at the appropriate time.
John, thanks so much. There's hardly any appropriate time left. Sorry, and we have to start with Stephen J., please. But all the questions, please put to question and answers. Steve?
Hey, great. Thanks, Manfred. And thanks again for Manfred and also IUSG and Dr. Gupta for the opportunity to speak with all of you in various time zones. And just to kind of bring some of these concepts together, Dr. Zerhut and I, are you able to see my slides okay?
Perfect.
Okay. So I need to... I'm just turning off the timings. Yeah, so to bring some of these concepts together related to bringing what we learned in the university to an emergency situation, I'll be speaking to these concepts related to our experience as a group with Ebola and also vision health system strengthening. I really appreciate all the comments of the other speakers as we think about these important topics related to how do we deliver uveitis care, provide research and education in multiple different types of settings. And so first, I won't go through all the names, but there's just so many people that we've been fortunate to work with, both from a mentorship perspective as well as others that we continue to mentor. And I really derive inspiration from individuals, both within the IUSG, AUS. Dr. Jessica Shanta, who's at UCSF Proctor Foundation, has done a tremendous amount of work, and Dr. Justine Smith and Nisha Acharya and many, many others in the United States, other countries, as well as West Africa partners who, without whom this work wouldn't have been possible. And so we're all really in a public health emergency, and we continue to be, and the global impact of emerging infectious diseases is clear to all of us. We've seen the headlines, and we continue to see the headlines to where we sometimes would just prefer to turn off the news at times. But some of these infectious diseases, again, affect different parts of the world. Measles, we've seen both in the United States, and last year was really recorded at high proportions, and we know about the different surges of COVID-19 that have occurred and continue to occur. But again, I'll be speaking more to Ebola, which has also continued to occur within West and Central Africa over the past few years. And so really, when we think about some of the fundamentals and the foundations of where this started from, it really was, again, thinking back what we learned in the university and related to some of these infectious causes of uveitis. These are conditions that all of us are continuing to learn about and see in our clinical practice and some of the high volume clinics, again, that Dr. Basu mentioned, as well as in private practice as well, whether it's syphilis, tuberculosis, the devastating complications of herpetic uveitis syndromes, or toxoplasmosis that we know, again, is a leading cause of infectious blindness and infectious uveitis that many of us are studying, as well as the arboviruses that can also lead to ocular complications. And so for all of us, again, we're understanding the balance between the systemic manifestations as well as the ophthalmic manifestations really is where it starts as we think about where this goes and how we can continue to perform clinical care and research and education in emergent settings as well. But what I'll focus on are this story really revolves around individuals such as this young girl, Aminata Kante. She's a young girl who we've had the opportunity to watch grow up. She's an Ebola survivor, and her story was published in the media. And she was an individual who survived, again, life-threatening illness from Ebola, but then developed uveitis. You can see her posterior sneaky eye and a dense cataractus lens, and her story was documented as Ebola's legacy, that we see other children who can develop cataract as well. Recent Ebola outbreaks within West Africa and Central Africa included the largest Ebola outbreak in history in 2014 and 2016 in West Africa, predominantly within Guinea, Sierra Leone, and in Liberia. Over 28,600 individuals were infected, and nearly 13,000 individuals unfortunately lost their lives. And the Democratic Republic of Congo outbreaks more recently from 2017 to 2020 in different parts, including northern DRC as well as eastern DRC as well as periodic outbreaks related to viral persistence. But Ebola virus disease, when we think about where Ebola tends to affect, is really a reflection often of, unfortunately, of fragile health systems. As I mentioned before, in these areas between West and Central Africa, there are a number of indices that we'll see in public and are discussed in public health circles. including metrics such as infant mortality, under 5 childhood mortality, and life expectancy. And you can see that these indices lag behind the world, as well as other more resource-replete countries, and also need to be addressed as we think about these settings where many of us have worked. Dr. Kempen, again, illustrating his experiences in Ethiopia. There's another development index called the Human Development Index that actually balances health, education, and standard of living. You can see these indices lag behind other countries within the world. And these are the systems that are quite fragile, and these infectious diseases tend to affect more severely. But it really became a global concern when international healthcare workers were repatriated to the United States, as well as other portions of the world. First with Dr. Kent Brantley and Miss Nancy Wright-Bull, who were evacuated from Liberia to the United States, actually to Atlanta at Emory University. And Dr. Ian Crozier, who was a critically ill healthcare worker who had kidney as well as lung failure, requiring critical care measures with all of the infection prevention and control measures. And his story was widely discussed in the media. And where I'm currently situated now is Dr. Rick Saker was hospitalized for Ebola, unfortunately survived. But in the context of Ebola survivorship, one of the Ebola survivors, Dr. Crozier, developed an aggressive vision-threatening ocular inflammatory process. And I really sought the mentorship of a number of uveitis specialists and really in his care. And he developed an acute hypertensive anterior uveitis, progressing to a scleritis with a hypopian, intermediate uveitis, eventually iris heterochromia. You can see his iris color change within about a 10 to 14 day period. It was quite dramatic, and ultimately a unilateral pan-uveitis. And unfortunately, with a number of experimental, actually with one experimental antiviral and a number of corticosteroid measures, including both systemic as well as local corticosteroid injections, he was able to recover his vision, and really more of a sigh of relief than a pat on the back. But in this context, we discovered that he had Ebola virus in his aqueous humor, and this was after his bloodstream actually had cleared the Ebola virus, and this was fully 90 days after his acute infection. You can see his pretty dramatic iris heterochromia, and again, the concerns about aqueous humor and Ebola virus in the eye really extended not only to the patient, but also to other individuals in West Africa and other countries where Ebola virus was being experienced. So at this point, again, thinking about this theme from moving from from university to an emergent setting, Dr. Jessica Shanta, Dr. Brent Hayek, and myself, along with Dr. Crozier himself, actually then traveled to Liberia to try to understand this process further. And we worked with Dr. John Fankhauser, who is the lead clinician and really a hero in the outbreak response. He himself was responsible for the evacuation of a number of United States healthcare workers. And with Dr. John Fankhauser, we set up a mobile eye clinic, including a really portable slit lamp equipment, indirect ophthalmoscopy, again, to try to understand the extent of this problem, looking at visual acuity and what it meant to individuals who had already suffered so much through devastating Ebola virus disease personally, and often affecting their families as well. And through this experience, we screened nearly 100 Ebola survivors in a fairly short period of time. We found that uveitis was evident in just over 20% of individuals, 6 of whom had bilateral disease. And it turns out that vision was impaired in over 60% of eyes, and actually met the WHO blindness definition of 2400 or worse in 40% of affected eyes. You can see some of the images here, including the chorotic precipitates, posterior synechii, choroidal scarring, certainly the potential for selection bias in this population, but these studies have subsequently or simultaneously evaluated by others, including Dr. Paul Steptoe. Also, the NIH had a very, very nice prospective study to understand this disease in Liberia as well. But since then, again, what does it mean to go from university to emergency? We've continued to evaluate this condition with the various degrees of freedom that I've alluded to, specifically related to the potential for Ebola virus persistence in our EVICT study. And I'll talk about a few of the details about deploying that research study in this setting. We've also looked at the impact of vision and mental health within pediatric Ebola survivors in a pilot, and we continue to work with a number of institutions on this program. And we've since been deployed with the World Health Organization Global Outbreak Alert and Response Network to really partner with Congolese ophthalmologists in building capacity in an outbreak setting to understand disease in Central Africa, as well as ensuring that they have the tools and the training and the skill sets needed to continue to care for patients in the midst of these recurring outbreaks. As I'd like to speak for a moment a bit to the EVICT study, which was the Ebola virus persistence in ocular tissues and fluid study, which was conducted in Sierra Leone. And again, in the context of the knowledge that Ebola virus may persist in the eye after and during Ebola survivorship, the question was, for individuals who have cataract, when could cataract be safely performed in Ebola survivors who had lost vision? The goals of which were to guide safe and vision restorative surgery for Ebola survivors based on evidence. And so it was a fairly complex study to set up, but it certainly involved a pre-procedure evaluation with the in-country ophthalmologists, laboratory investigations. You can see Dr. Crozier involved in the consent and counseling process, both with a group setting as well as individuals, as well as a setup with a procedure room design that we worked with infectious disease physicians on that required a personal protective equipment donning area, a red zone where the procedure were to be performed, again, with the concerns that we could potentially have Ebola virus exposure, and subsequently a doffing area or a transition zone to ensure that we have adequate infection prevention and control precautions. And this is a prospective study, again, approved through the IRB and with the local Ministry of Health. We had enrolled 50 patients. All of these patients were young age, within their 20s. And the median logMAR visual acuity was 3, or about the hand motions range, again, meeting criteria for WHO, criteria for legal blindness. The majority of these individuals had visually significant cataract. There were other indications that we also chose in the study. The mean time post-acute Ebola virus disease ranged in the 2 phases of the study between 18 months and up to 36 months or 3 years. So this was quite long after their acute infection. And of these 50 patients, we assessed primarily aqueous humor specimens, but 49 aqueous humor and 1 vitreous specimen all tested negative for Ebola virus by RT-PCR with our partnering lab in Eastern Sierra Leone and Kenema. And we also performed pre-procedure and post-procedure conjunctival swabs that also tested negative individuals. And we only did this in the first phase of the study. And the patients who, again, tested negative for Ebola virus, who had cataract and elected to proceed with cataract surgery, underwent manual small incision cataract surgery with a very talented in-country ophthalmologist, Dr. Mogus Tasham, at the time with infectious disease oversight. And fortunately, from an outcome standpoint, we were pleased with their overall outcomes, that the majority of individuals improved in their visual acuities, improving from a median of hand motions to around 20/30 at the 4-month range, and we're continuing to follow these patients. And interestingly, our learnings and the protocols that we developed in West Africa were utilized for our individual who had developed a cataract within the United States as well. And so protocols that we had developed embedded with the ID physicians who actually traveled with us to West Africa to work with our wonderful West African colleagues. These protocols were again deployed at Emory to take care of our patient in the United States as well, who achieved excellent vision after cataract surgery with Dr. Jill Wells. So since then, we've gone on to, I wanted to briefly mention a very nice study, again, thinking about the pathogenesis of disease by Dr. Justine Smith, and this publication in Transitional Vision Science and Technology assessed RPE cells and showed that these cells were indeed permissive to infection with Ebola virus and supported viral replication and eventually release of virus in high titer. And really, I would encourage all of you to take a look at this manuscript, but it really looks at the virus RPE interactions that immunologically may contribute to long-term persistence of Ebola virus. And this paper, in combination with some of our work from our other colleagues from USAMRIID, which also showed that Ebola survivor rhesus monkeys can also develop Ebola virus persistence in their vitreous, actually led us to develop the study that's currently ongoing to assess further the pathogenesis of uveitis and Ebola virus survivors in Sierra Leone. This is a three-part study. The first aim is to assess the prevalence of uveitis at long-term follow-up and risk factors for individuals who have survived Ebola who may develop uveitis. We're also looking at molecular diagnostics to evaluate vitreous fluid for Ebola virus persistence, and in that context, looking at building capacity for vitreoretinal surgery. So I really appreciate Dr. Kempen's comments on subspecialty care as well with his experience in Ethiopia. And lastly, we're working with some of our immunology partners as well as our partnering labs in Sierra Leone to evaluate immunologic T and B cell responses in Ebola survivors with uveitis as well. So what are some of the challenges that we've confronted, and how do we approach outbreak and emergency response for eye disease? Well, some of the challenges Dr. Kempen alluded to, but these can include resource limitations in regions where the outbreaks may occur. There's a opacity in some regions of infrastructure, equipment, and sometimes subspecialty training. But really, I think that these are areas that we can continue to address and really dissect to figure out how do we address these, both from funding as well as building capacity. And some of these approaches, again, can include infrastructural support and training in centers where outbreaks are likely to occur. I think that the innovations that we have, both in telemedicine and artificial intelligence, may play a role that we can think of in the future. Certainly rapid response teams in coordination with public health authorities, with the WHO, the CDC. We're currently working with the WHO Global Outbreak Alert and Response Network that responds to some of these situations. And the more rigorous studies certainly can require more funding, as well as an additional constructing the data platforms. But these are the prospective controlled natural history studies, and certainly important to continue to partner with larger organizations who can conduct these studies over a longitudinal period of time as well. So moving forward, more recently, we've deployed with again the GOARN, or the Global Outbreak Alert and Response Network, to Eastern DRC. And this was a very challenging region to work in, because within Eastern DRC, we have some of the security instability that we see in certain areas. But we really needed to go under WHO bridge with also security support to work with the Congolese ophthalmologists. But we were able to conduct a symposium on eye disease and with Ebola, related to Ebola survivors, as well as provide care for several hundred Ebola survivors in the context of, again, strengthening educational platforms and building capacity, as well as thinking about opportunities for eye care and vision health strengthening for DR Congo in the future. These are some images of our partnership. One of the nice things about ophthalmology is that these skill sets are really quite modular. You have the visual acuity station. We think about ocular vitals, checking pressure and visual fields, but also guiding ophthalmologists through finer aspects of the slit lamp examination. Portable fundus photography. You can see Dr. Crozier using his fundus photography skill sets with one of our very talented local staff, and Dr. Jean-Claude Mwanza, who is our really fantastic ophthalmologist who has a dual appointment at the University of North Carolina, as well as the University of Kinshasa, with one of his colleagues, again, practicing indirect ophthalmoscopy and B-scan ultrasonography, as seen here. And again, through these stations, a number of the images of how we can think about providing care, again, in settings, while also partnering this with educational initiatives as well. One of the aspects that COVID-19 has taught us is that we really need to be flexible in terms of how do we think about global health. And so partnering with MedShare, which is a non-governmental organization who specializes in supply chain, we've been able to support some of our Sierra Leonean colleagues with personal protective equipment. We're continuing to partner with other institutions related to thinking about vision health and how it affects quality of life, as well as mental health. And as I mentioned previously, understanding eye disease and the pathogenesis of uveitis and Ebola survivors with ongoing programs, and really building, hopefully, retina subspecialty care and other subspecialty disciplines in the future. Moving forward, we have a strong commitment to health access and security, and a commitment to women and children, as well as, again, some of our strengths related to research in technology and innovation, leadership in science and medicine through a West African Center of Excellence in Vision Care. And for anybody who's interested, I'd love to continue the conversation about how IUSG could partner in some of these efforts that are ongoing, and important aspects of human capital development with gender equity in educational leadership, really to address these disparities. We were fortunate to have our first ICO fellow, Dr. Harrison Williams at Emory, actually about a year and a half, maybe even a little longer ago now, for medical retina and uveitis. And so it was really wonderful to have him visit us there for several months as well. And so I'll just summarize again by just emphasizing that infectious uveitis caused by Ebola and other emerging pathogens really continues to require our characterization of these phenotypes, viral persistence, and ultimately immune response. And advancing these programs can be challenging, but really requires strong partnerships, coordination with local ministries of health, ophthalmologists, all of us on the call this morning or afternoon, wherever in the world we happen to be, as well as local staff and engagement with the international scientific community. And ultimately, vision health system strengthening is really needed in the way forward as an entryway to both clinical care and understanding diseases that we'll all need to understand and treat in the future. And thank you again, Manfred, for the opportunity to speak with you this morning.
What a pleasure. Thanks so much for the nice presentation. So let me summarize the webinar with my presentation. So let me actually inform you about the concepts which ISG has for people who want to learn about uveitis. That depends, of course, of different situations. You may be already an expert, or on the other side, you may have started with ophthalmology. Few words to ISG. It's the International Uveitis Study Group. First years was founded in 1978. It was just a meeting of friends. Discussion of case reports and new research publications was in the center of the meetings. I became a member in 1996 and have the great chance to be the president until the end of this year. So let's see what type of education we have. This starts with the highest degree. If you're really an expert, I think you should join the ISG, and you will see education research. If you're specialized for uveitis, we have different courses, webinars, and so on. If you're more a general ophthalmologist, I will report about the patient support system, which is actually available for all general ophthalmologists. And even if you're not living in an ISG country of members of ISG, we start now the ambassador support system, and hopefully that also brings in some good information. So how can you become a member of ISG? There are multiple people during the webinar who have asked, who would like to become a member? Well, it's a group of experts. That means you should have 5 years of uveitis after residency as most of your work. You should have published 10 publications in peer-reviewed journals, 5 as first author, all about uveitis, scleritis, something like that. And we have, in the moment, approximately 140 persons worldwide. So something which we offer for the members of the ISG, but also, of course, for highly interested people. These are international symposia on uveitis, the ISO meetings. We have 9. The chance to join 2 of them, to prepare 2 of them, to organize 2 of them. The next one will be approximately beginning of September in the Netherlands. So if you're interested in joining such a meeting, you're more than welcome. Go to our website. Then a few years ago, we started to create another meeting, which is a little bit more clinical. We call it Inflammatio. It has been done in Chennai and Tel Aviv. In addition, for our members, if you're really a member of the ISG, you get the peer-reviewed journal Ocular Immunology and Inflammation for granted. And actually something which helped me a lot also to understand uveitis and the needs of uveitis patients is to have been the president of the patient interest group for, well, quite a long time. So, you know, these big meetings, they are probably fantastic if you want to meet friends, if you want to exchange your own experience, then this is absolutely necessary to join us on such meetings. This is constant 2008. Sophia Andrudi here and Bahram Bodagi from the IOIS here. It's a SANI meeting in Greece. These meetings are absolutely necessary. Here you see previous presidents of the ISG. But when this is probably a little bit too strong, because there are a lot of abstracts with case reports and so on. If you really want to start with uveitis, we would offer you uveitis courses. So in the last 20 years, approximately, the idea started to have a strong uveitis program, let's say for 6 days at a beautiful spot. Why not going to Venice? Exceptional time point. Well, why not going to the carnival? If you can pay that, and it was possible to pay that. And we started in 2007, the starting year of the first Venice course. And in 2019, we had already the 7th course, 21, of course, no course because of pandemic. Well, probably if you're aware of Venice, it's a beautiful spot in this world. Here's St. Marcus Place, and here this is our island. It's the San Servolo Island, where we have the International University, where we also stay together for some good prizes. So this is payable for our course. This is the entrance of San Servolo, and here in these rooms we have our courses. These are the flyers we prepare for each one. Here are the costs, which includes also the rooms, actually, for participants. This is the faculty, which gets exchanged more or less every second year, something like that. So it's okay for ISG members to stay in the faculty for 2 years, but then we want to have some new ones. So you see, coming from Saturday to Friday, coming Friday, we have a full program. Only exception is Tuesday afternoon, the end of Mardi Gras or Carnival, where we are going out to celebrate the Carnival. This is a certificate which everyone will get after the course. Well, after the course is free for everyone. We enjoy Venice, of course. Sometimes it's not only enjoying, because sometimes you have agua alta, and that needs some special solutions, like in this situation where the fun really stops very quickly. But coming back to fun, it's Carnival. It's beautiful at that time, especially also in the evening. It's a very, very beautiful, romantic way to celebrate Carnival. And I think this was always a nest since years. We have the right reaches that we have pictures without the masks, the whole group of uveitis people, and here with masks. And this is also very nice. Here, Stephen Foster. Actually, this was my mask last time. Well, staying with Venice. An important point for Venice is that we give grants. This grants means we can select people, typically one from each country, no more, not two from one country, typically from Africa, and they get accommodation free. They can get a travel grant for 800 euros, and they get a grant for personal costs for 30 euros per day, which I think is a wonderful support already. And here you see the grant winners, mostly here from Africa. There's Nick Jones here just on action, and here just in the evening, then we go to St. Marcus Place, and that's me in the group of the grant winners, which really came from different countries in Africa, but also from Kiribati. Probably you have heard about this one. Kiribati is a group of islands of 3,000 kilometers south of Hawaii, north of Fiji, and it exactly has one ophthalmologist. And it was a pleasure to invite that lady to us. And I had the pleasure on the other side to visit her next half year later in a very poor community. And it's fascinating. Well, then we had John Campen with us. You've heard John Campen as lover of Africa, and why not bringing this Venice course to Africa? Why not to Addis? So we did the same thing. Things were much cheaper, fortunately, and we were able actually to have a course in Addis Ababa with filled rooms, a lot of fellows and residency people, and here even our friends from Sudan who will hardly have a easy time to leave the country. Here's a faculty, a little bit smaller than for Venice, but the same program, exactly the same program. And this is a picture here from the Thursday rounds. On the Thursday, people should use what they have learned in the previous days. They get case reports and they should discuss these case reports in front of us. And we will try to illustrate, to make it possible to solve these sometimes really complicated cases. Some impressions from beautiful Ethiopia with again a certificate. And finally, we were able also to visit this amazing country, which I think during the Civil War it will not be possible here. And you wouldn't believe, in 2020, one of my last courses outside of Europe, outside of Germany, we had a second Venice course, this time in Africa, this time in Accra, in Ghana. And you see the faculty here with a whole bunch of Ghanaian residents. This was a very, very important and great meeting. Well, if it's difficult to travel to groups, to doctors, and to give presentations, why not visiting countries, small countries, which probably only have 1 or 2 or 3 doctors, and then to teach uveitis case by case. So that's what I did to achieve actually my traveling in my life. I think I've been to all of these countries, definitely not only with the ISG, with bigger meetings, but only to visit probably 1 or 2 ophthalmologists, to enthusiasm them for uveitis and to see a lot of various patients. So we talked about support of general ophthalmologists. I presented you uveitis courses, but then we have the patient support system. And for this one, which I highly can recommend, please join our website. The patient support system consists of the following one. If you have a complex uveitis, but no uveitis specialist who can help you, you can submit this case to our website. And this will be submitted to a moderator, which changes every month. He will then consider the whole case report, if it's okay, if there's something missing, and then submit it to our official website. This is available for all uveitis ISG members, and they will send the feedback of this case to the moderator, and the moderator will give this to the support, to the first doctor ophthalmologist who submitted that case. So this is free actually for all ophthalmologists. They only have to register, but this is worldwide possible. And in the moment, we have approximately 2 to 3 cases. It would be nice if you can use that system. Again, go to our website. There's a patient presentation system you will find easily, and there's a whole description how you can interact with us. Webinars. Well, you're just in one of our webinars. We started in January 21. Today we have the 13th. We are planned 36. I think very nicely is that it's visible on demand. So even if you're not able to participate today, which is with different time zones really a problem. You should be able to see what we planned, what our speakers can tell you. And now you are getting a little bit more interested in uveitis and you want to become a uveitis expert. So why don't you want to join an ISG member with a grant? Please go back to our website again, and there you will see a list of education of all ISG members, starting from A to Z country-wise. And there, all the members, without emails, of course, will show exactly what grants, fellowship they can cover when you bring the money with you, of course. Yes, this is necessary. If you're interested to visit Paris to one of these people or to Germany, please contact our secretary and we will definitely be able to help you. So then we probably have a situation with countries where we do not have ISG members. Of course, 140 members only, this needs a little bit more. And we started the system of ambassadors of uveitis. So if you have a look for this map, all the yellow countries have ISG members, so they are able to cover more or less their country and probably also a little bit the surroundings. But we also have ambassador countries. That means we have people sitting, for example, in Colombia, taking care for Central America, even for the Caribbean, even for Ecuador and Peru. If you want to have more information of that one, please contact us. As you can see here, we still have a big need for West Africa. Stephen, that's your part. It would be lovely to have you as an ISG member and to make you to ambassador of that part. John already mentioned his part, which goes down from Ethiopia down to nearly close to South Africa. So we have a lot of countries already covered. And this is a list of our ambassadors, and that's growing. Even in Fiji Islands, this is the only eye clinic in Fiji Islands where I had a chance to give presentations. They are also joining this program. And let me end up with one recent project. I think we need also challenges for ISG members, and something we want to do, we are just starting with that one, is working groups. The idea is uveitis is part of a systemic disease. That means we as uveitis specialists need the help of, for example, pulmonologists, of CNS persons. So we are looking for cooperation with interested scientists of these associated disorders. Vitreoretinal lymphoma and toxoplasmosis will be the first one which start, Behçet's disease the next, but of course for tuberculosis, sarcoidosis, HIV infection, plus probably a few more, we definitely also need such working groups. So in conclusion, I try to show you the possibilities you have to join uveitis on the step ladder, which you can choose. If you're really good already, you should become a member of the ISG. If you want to get specialized for uveitis, follow our courses. Hopefully in 2023, we'll have the next Venice course. Africa, we really don't know. We have now 36 webinars planned, and join the ISG member with a grant, any of our ISG members. For general ophthalmologists, we strongly support the patient support system, which also, of course, is a great education system for our ISG members, because there are some rare things in to discuss. And for the non-ISG countries, we really would love to see you in the ambassador support system. So with that, I want to end. I hope that this webinar was interesting for you, gave you some brilliant ideas, and I hope you have a lovely weekend. Well, before I end that, please feel free to ask your questions and answers here under this point here. Well, it's just 3 o'clock, but actually in the program, you see that we have still our panel. And let me quickly tell you what I plan with the panel. Probably it only will take a very few minutes. The panel starts extremely basic, and I would like that everyone from the faculty listens to that one and comments when they feel they should give some kind of comment. So the question is, you start with an idea, uveitis. I think everyone told you you can hardly become a really very, very rich person with uveitis, but it's a beautiful thing to help such people as a specialist. This is amazing. So your idea is there. You need education, of course. I think we all gave you some good examples where you get your education. Well, then in the next one, you need some kind of plan. Plan depends a lot where you come from. If you're coming from a high power country to an emergency situation, this is definitely easier probably than, for example, the situation Sumyava Basu had, where he left academic and went to a high volume clinic. There are different situations. And Mark, I think, is in the middle. Very difficult, definitely the situation of John, but this is really very, very challenging. And I admire him really a lot about his plans and what he has done. So then if you want to start, I think you have to clarify this with your bosses. If you want to do that in private practice, good luck. That's fine, but probably it may be a little bit easier to start in an academic situation in a hospital or something like that. What about starting with 1 day per week to make things easier, to develop things? Then you should find probably some people which are also as enthusiastic as you, some, let's call them co-workers. Yeah, I think it's interesting to educate uveitis. So if you know already things, it's beautiful to teach uveitis to others. And I'm sure you will find easily some residents, fellows, or whatever, which really are a big help for you later on. Something especially, I think, Sumyava and Mark mentioned, you need contact persons. You need good labs, definitely after some time. And you need people like pediatrics. Very nice example, Mark. I completely agree. There are big, big differences. And even in Europe, there are big differences. This is amazing. You need pulmonologists. I can tell you, pulmonologists still believe that tuberculosis is exclusively a lung disease. So there's a lot of things not correct yet. And I think they need also some information from our side. So I hope our working groups are really going into such a direction. And of course, infectiologists. I think if you have a chance to have such people with you, it's not a specialty in Germany, actually, but I see the situation in India and in the US, and this is really very, very good. My friends, you want to comment a little bit to this one?
Yeah, if I may, I'll add a point on connecting with other experts, especially those who do not understand ophthalmology or uveitis so well, and you gave the example of tuberculosis and pulmonology. Yeah. So it's very important that we take up case examples and share with our pulmonology friends and show how treatment with anti-TB drugs is making a difference in this patient. When they see those live examples, they are convinced, and they kind of become friends for life. So thereon, you know the right person to whom to refer your patients to once you have to deal with, let's say, treatment of tuberculosis. Same applies to any other, rheumatology or dermatology, any of these specialties.
I think a nice way would be to contact such people and to give them some kind of presentations about a JIA in the eye, something like that one, which also refers not only that's a local problem, which is completely irrelevant and not true, but to show what has been done nowadays with good treatment, systemic treatment, something like that. Same with tuberculosis. Yes, I think this is very important, and that creates a lot of trusting situations.
Maybe I'll make a comment on what you said earlier. Do you want to go first, John?
You can go ahead.
I just wanted to make a comment on what you said at the very beginning, Manfred, on starting small with 1 day a week, for example. I think one of the things that Sumiava mentioned also was to have protocols, and these can come from where you did your training, if you've been able to go for training. And I think part of what you showed also, John, is what the approach is to how to treat uveitis, and some of it is either in our head or written down. And one of the things I think we could do with the IOSG is to take some of these protocols and make them available through our website to sort of help people get started if they need to. I think starting small and having good support, either from your own mentors and from local people, I think is an important way to get started.
Protocols means
John?
treatment protocols?
Treatment
Or
protocols,
diagnostic protocols?
the type of support you need, getting started, whether it's in a private setting or in a hospital, is a daunting experience, and we all have some of that experience. And certainly when I started, even at the NIH, I read some of the articles that Steve Foster had written on how to screen for patients and others. And over the years, we've all developed our own approaches, and I think it would be good to make it available.
Mm-hmm. Good idea.
John?
Yeah, like the guidelines paper that was made back in 2000 is, 20 years ago as well. So there could be a good thing to do there. I was going to say too, I think it's really important to, go around to meetings and to, talk about our concepts, because people in developing countries and in every country are very busy with their practice. They're under pressure to produce revenue, whether for themselves or for their institution, and they don't really, we need to kind of get their attention. So I think going around like what you've done, Manfred, and sort of presenting experience and so on, it really makes a difference. Like I mentioned the course that we did back in Rwanda, and I think, that really made a difference. And if I, unfortunately, we haven't been able to have conferences the last 2 years in Eastern Africa, but when you present like a case that, no one knew what to do and they were getting worse for 2 years, and then you realize it's tuberculosis and then the patient's cured, this sort of really opens people's eyes, or you see like a VKH case, that is a disaster, and then you have another one that, what the disease was recognized and you manage them and they're perfect, these kinds of things.
So I remember in Rwanda, we started easy to ask, what is the dominant type of uveitis? They didn't know.
Yeah,
they were not even
exactly.
able to differentiate interior from posterior uveitis, which is a simple basic, and it's such a simple step to improve the situation of patients. It's tremendous. But on the other side, my teaching experience in Africa is fantastic. Yeah, I love to go to Africa. These people are amazing. Yes, whatever they hear, they keep in mind. I'm absolutely surprised, and it's a super pleasure for me to go back to Africa. Hopefully, we can do that together in some time.
Yeah, I mean, actually, the ones who are doing it in Africa are the ones who take every opportunity to learn whatever they can, and so they're extremely receptive and very sharp.
Amazing. Yes.
Yeah.
Yes.
Yeah.
Yes. I've seen even people which had a grant from Venice. I visited them in their country, and they were simply entertaining the other doctors with what I wanted to tell. It's fantastic. Yes, it's amazing. Yeah. So never give up. Yes, our impact is dramatic. It's not good. It's dramatic, definitely. Yes.
Yeah.
Okay.
And I think we need to keep focusing on Africa too, because it's really an unreached area for the most part. Beginning to have some. Yeah.
So one more word for people listening now from Africa. You know that we have different categories of ISG members. The full ISG member I presented. This will be probably a little bit a problem for you to publish 10 publications plus 5 under your own name, but there are also associated members. And if you would love to participate in that one, please go back to our website, check what's an associated member, and probably you should try to contact us. And if this is possible for us, we definitely are interested to work even with an associate member.
Manfred,
Okay.
could you navigate to the website where you submit the cases? Like I couldn't find it when I just looked just now, just for people who want to submit cases to IUSG.
Oh, I don't know exactly. Mark, can you do that?
Ooh.
It's
Let me
called
see if
patient
I can.
support, I think. Patient support system.
Let me see
It's
if
on
I
the
can
top
do it.
line there.
One sec.
Yeah, you need to go to Ask Advice and you'll probably find it.
Mm-hmm.
Request
Oh, I miss.
patient presentation system.
Yes, exactly.
I may share my screen here. This is
Oh, yes,
how it
yes.
is.
Ask
You have to click on
advice.
Ask Advice and you find the patient presentation system and request IUH advice with the download template here.
Great.
Yep.
Very good. Again, I forgot to tell that if you're a submitting ophthalmologist, you have to download a template and to fill in the whole history of your patient. And probably one more point, this is free for you as a doctor and free for the patient. Okay? We do not ask for any money for this one. Okay, with this, I think I would like to tell you that was a pleasure with all of you. Very interesting topic, very unusual topic, necessary topic. Thanks for this suggestion from to the person who did that. I forgot this name. And I think we will meet again in the first Saturday in February, then with JIA-associated uveitis. Thanks so much. Could
Thank you,
I
everyone.
shortly ask the
Thank you.
faculty to check the questions if there's anything?
How can we contact with Manfred Zero?
Yeah, I do that. Okay, otherwise, if you're done, please enjoy your weekend. Thanks so much.
Yeah, thanks everyone. Good to see everyone.
Yeah. Take care, everyone.
Bye.